The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. We'll just start in a few moments. We'll just give it time for everyone to join us today. So welcome everybody to today's webinar, Marketing Fawlty Towers, 4 Ways to Restore Long-Term Care. My name is Romilly Douglas and I will be your moderator. I'm pleased to introduce today's speaker, Irving Stackpole. Irving is the president of Stackpole Associates, a strategy, marketing and research firm founded in 1991 with decades of experience in healthcare and senior living. Before I hand over the microphone to Irving, I have a few housekeeping items to cover about this presentation. First, today's webinar is being recorded and will be made available via email to all participants after the webinar for further review and sharing. We'd love to hear from you today during today's presentation, and we'll be answering your questions at the end of the session. If you have a question for Irving, please send it through the Ask a Tab question at the bottom of the control panel. If we don't get to your question during today's webinar, we'll be sure to follow up afterwards. So without any further ado, I'd like to kick things off by welcoming Irving. Thank you.
Thank you, Romilly. It's a pleasure to be here. My hope is that our time together is fruitful for those of you who have carved out the time to be with us. And the topic today is a bit irreverent, but extraordinarily important. Of course, I'm referring to long-term care, which is at a crossroads, both in the United States, the UK, and elsewhere. And I'm using the image of Fawlty Towers, the famous or infamous John Cleese comedy program, built around a care home in the United States and its adventures, or should I say, misadventures. So what I hope to talk about today is the current situation in care homes and long-term care, focusing particularly on the UK. Talk about some myths, one myth in particular about aging. Talk about, of course, the COVID-19, which is at the center of the current crisis in the sector. Review likely recovery models and some scenarios. And more importantly, or very importantly, effective responses. How can managers in the sector respond effectively during this crisis and immediately afterwards, and focus those possible actions on the 4 strategies that we've seen work in other markets and in other circumstances when there's challenges, crises in markets and they decline. So the first myth I'd like to address has to do with aging itself. There's quite a bit of humor in this photo, but there's quite a bit of buzz associated with the size of the aging population and the number of individuals in it. And this myth has been promulgated widely. And the myth is that there's just a lot of age-targeted, age-appropriate consumers in the sector. Well, the truth is that in England and Wales, and the situation in the United States is very similar, the primary age at which consumers begin to more aggressively consume long-term care services is 85 years of age. And if you look at the number of live births in the United Kingdom in 1935, you can see that that's when someone in 2020 would be 85 years of age. And you can see here that in 1935, live births in the United Kingdom were at a low point. And they remain at that low point for quite some number of years, 7 or 8 years, and then they begin to increase again. So it isn't until 1942 that the live births in the United Kingdom started to pick up again. So between 2020 and 2027, we will be experiencing more of a drought, more of a dearth in age-qualified consumers in the long-term care markets. Now, this is often overlooked or not discussed at all, even in academic papers, and this is a dramatic oversight. And the important thing for us is that the market for long-term care services in the United Kingdom and in the United States, even before COVID hit, the market was terrible. It was bad before the pandemic, and now the pandemic has ravaged congregate care in the United Kingdom. And you see from a ONS-derived graphic that appeared in the BBC, these quote-unquote excess deaths in the dark red here associated with COVID in care homes in England and Wales. And actually, one would need to do a very careful analysis of above the benchmark line of 2019 deaths to determine which component of those are actually traceable to COVID-19. Perhaps COVID-19 wasn't mentioned specifically on the death certificate, but actually either was a primary contributor or actually the main cause of death. So it's a significant crisis. And the issue with the crisis, of course, is that it's an unexpected event. But what damage does the crisis do to our brand? What is the brand of long-term care in the UK and in the United Kingdom, Wales, Ireland, and in the United States? Well, the brand is indeed Fawlty Towers. It is a negative metaphor in general. And fact number two, the brand now is damaged. And we've heard so many times from so many clients and at so many conferences, forums, newsletters, research reports, phone calls. It'll never happen here. We have a great reputation. Families love us. Local authority love us. We know what to do. My team can handle it. Well, truth is that this is a seismic change in the negativity with which the public views congregate long-term care. And the news media, as you can see from the 4 News article here, a feature piece that appeared in, I think it was in April or early May. This is just a field day for the media to sell negative stories about the sector. So what's different in this situation is that the entire sector is under siege. This is prompting or stimulating latent guilt in our cultures about not caring for grandmother at home. It has no end in sight. There's no specific end that one can point to. And the fulfillment or production is threatened. And by that I mean the staff are equally threatened in care homes and nursing centers. And that in turn has the corollary or the obverse question: who wants to work for you? Who would want to work in a sector that's being so ravaged by this disease? So the recruitment and retention is an enormous challenge in regular circumstances, and now in this crisis, it's accentuating or exaggerating the negative impacts of the economic model. It's bringing home the fact that in care homes and nursing centers in the UK and the US and other places, there's a very mixed inventory. It's difficult to be consistent and have consistent standards when the inventory ranges from very small care homes with only a few units to very large centers that are custom built. The other issue with recruitment and retention is the regulatory burden. It's a very difficult environment to work because of the regulatory component. And we just learning recently that the Public Accounts Committee in the UK is publishing its review of the need for guidance in the long-term care sector. Much overdue, but this is the type of regulatory scrutiny that will result from this COVID crisis, which has been needed for some time, but which has the risk of holding significant untoward, unexpected, and unpleasant surprises. It also has the potential for creating some very positive changes in the sector, and the role that we as providers and as organizations, the role we can take in directing that, I think, is tremendously important. The other thing in recruitment and retention is this issue around negative cultural bias toward care homes, toward long-term care, toward nursing centers. This has a direct impact on recruitment and retention as well, making the job of finding and keeping qualified staff, qualified personal care attendants very, very difficult. So in the UK, it's a pretty big sector, and there's about 1.2 million individuals who work in long-term care, and this includes nursing homes, domiciliary care, community care, and care homes in general. And you can see that the vast majority here, 610,000 work in people's homes. It's a large group, it's a diverse group, and it's a very low paid wage group. And you can see here from data looking at job losses in the United States and the United Kingdom, which payroll cohorts, which pay rate strata are being most impacted by COVID. And you can see that the low pay wage groups are being disproportionately impacted by unemployment at this time. So we can see that the means of production, which is another way to say that's our staff, they are our means of production in long-term care, they are being outsized impacted in a negative way by the COVID-19 crisis. The Skills for Care did a survey pre-COVID and looked at difference between leavers and stayers in care homes and in long-term care, the adult social care workforce, and we can see that there's a disproportionate and growing number of individuals leaving versus staying. So it's extraordinarily important to zero in on this component as we look at issues such as regulatory burden, as we look at issues such as the economic model, to look at how adult social care, long-term care, congregate care can become more competitive in the workforce, in the labor markets. So, summarizing about staff, we have a situation where we're struggling for recruitment. It's difficult to retain staff under the current, it was difficult before COVID, and it's even more difficult now as unemployment surges in other situations during economic downturns or regular, your standard run-of-the-mill recession. You'd look at unemployment growing and say, well, is this an opportunity for me to recruit from an unemployed group of individuals in my local marketplace area? But the question becomes, is long-term care an attractive alternative for suitably qualified, motivated individuals who become unemployed? And that's a very good question. And that raises the question of how do we communicate the relative advantages, disadvantages, and features and benefits of recruiting staff to work in long-term care. There's been some interesting research done on this, but we don't see these research reviews, these peer-reviewed studies, we don't see them being implemented by care providers the way we hope they should be and could be. So struggling occupancy, struggling recruitment and retention. The economic model is struggling. We have old inventory, onerous regulatory burden, and negative cultural battle. Pretty chipper assessment, I'd say. Overall, it's quite a situation. So how do we recover? Well, among the models of recovery, we look in general at economic modeling to see what's likely. And in this current situation where the responses, the public health responses to the disease have been remarkably inconsistent between and among countries, and in the United States, between and among states, what we see most likely is a recovery model where we begin to recover, and then there's stabilization or deterioration, and then we begin to recover still further, and there's further stabilization or deterioration, et cetera. And that's the way we see this recovery occurring. Alternatively, we could see recovery and then another wave. People haven't been really talking about the second wave of SARS-CoV-2, the novel coronavirus, but that is looming. Most of the discussion has been about what's occurring still in the first wave, but we have a second wave of the virus to anticipate. And we can hope, we can pray that there will be a vaccine available and effective treatments available. But the fact is that this pandemic will follow the path of previous pandemics, and there will be a second wave, which may mean that the type of recovery we have will look like B4 rather than A1. So the factors that will be important to rebuilding and restoring the brand of long-term care post-COVID have to do with acceptance of congregate long-term care and long-term care overall, have to do with acceptance of it in the cultures. So in the UK in particular, how well is long-term care, in particular nursing care, adult social care, how well are they accepted? And the flip side of that is to what degree it's actually utilized. So, and that's the term penetration. So we look at that carefully to see what impact acceptance will have on penetration. And there's always trade-offs. There's trade-offs between the risks associated with moving into or considering utilizing long-term care. And there's always a trade-off between doing nothing, what the status quo is, and the advantages of accessing or utilizing long-term care. So from a sales and marketing point of view, from an acceptance penetration point of view, long-term care is a solution that's almost always pitted against the status quo. No, we can take care of this. No, we've got mom covered. Well, you know, if I just change my schedule at work, I can handle this situation by going and visiting mom in her flat from time to time. So what the trade-offs are between the accessing long-term care and the status quo. There's also, as we already alluded to, the issue of government and regulatory intervention. It's an enormous challenge. Governments across Europe and in the United States do not have very good regulatory monitoring and surveillance schemes for long-term care. The reasons for that are multiple, but have to do primarily with the relative importance of long-term care in the panoply of issues that governments need to deal with. And frankly, long-term care has been relegated to secondary or even tertiary importance. But yet, The regulatory intervention looms its head whenever something bad happens and makes it into the press or makes it into a politician's front of mind awareness. And that's what we need to be wary of and need to be concerned with. And this is among the things that we as managers, we as operators and or academics have an opportunity to influence going forward. We will probably see more onerous regulation. One can hope, one can plan, one can push back, but I believe we're going to see more onerous and perhaps even more inconsistently applied regulation. One of the issues in the UK and in the US has been that the regulatory body in the UK, that's CQC, that they have applied the regulatory standards with a high degree of variance. How homes in Lincolnshire are evaluated by their authorities is very different from how they're evaluated in another location. So the difference between how the regulator looks and assesses care home outcomes, care home standards in one place is highly variable, and that's certainly a problem and increases the burden for us who are attempting to operate and work within those regulatory standards. And the one issue that hasn't been talked about very much, I think some private groups are beginning to talk about this and address the issue of liability protection and exposure in the insurance markets. COVID is opening up this issue about liability protection, malpractice, protection from lawsuits. We're just beginning to see the ripples of these impacts in management and in ownership of the properties, the assets in the sector. So post-COVID-19, the likely recovery models are going to, we're not sure about the depth, length, and the shape of the recoveries. I see two possible scenarios. Scenario one is that the sector is rebuilt and recharged. There's certainly a number of people who are looking at what's needed in the sector. Innovative ideas are circulating, and I think there are lots of ideas on the table, but what I'm concerned about and what we should all be prepared for is that it could be ravaged and further relegated when so many issues need to be tackled, so many political hot potatoes, hot subjects are to be dealt with. Will long-term care, care homes, and continuing care, will it be further relegated to the dustbin of public service issues? I'm not sure. But I don't want to leave without talking about what it is that we can do. And these are all concrete steps which we've seen work. We've seen work in multiple places and which we've imported from other sectors when necessary. So what we can do, number one, in our operations, regardless of where they are, is we can take responsibility for the messages. We can take responsibility for the narrative. And I believe strongly that we need to move and shift the storyline around long-term care and the value of long-term care to the community, the value of long-term care to its consumers and its residents, and the consumers include the families. We need to take charge of that. And I don't mean portraying ourselves as victims, because I don't believe in the long run, victimhood will shift the narrative. It will not create any long-lasting or durable change. And while it may garner immediate sympathy or empathy, it will not, in the long run, reposition the brand of long-term care as being important, as being valuable, as being a good, socially sensitive and and exciting and stimulating place to work. It won't change any of that. So we need to take charge of the narrative, and we need to tell the stories and show the images. And I know this is particularly fraught in the UK with its tenuous relationship with the news media and news outlets. News media and news outlets are always looking for the negative side of a story, because it is, unfortunately, the negative stories that sell newspapers, that garner clicks on in the digital sphere, and the more clicks, the higher the value of the ads that get placed in those channels. So the negative stories do indeed garner the greater attention, but we have a responsibility to develop a very consistent, regular drumbeat of positive stories and important contributions that long-term care is making to the communities we serve. What we can do, number two, so this is the second piece. We can fortify, protect, and defend the market share that we have now. And one of the things that we absolutely need to do in the long-term care sector is we need to review our digital assets. We have, as providers, owners, managers, as consultants to the sector, we have been neglectful of websites, of e-newsletters, of our Facebook presence, and this is showing up to our detriment now in a crisis when families are relying on these digital channels now more than ever. This, in the crisis communications mode, which is where we are, we have a responsibility for communicating and managing the story with families, employees, our fellow providers, local authorities, and other stakeholders. It's up to us to manage the message. We must accept and understand fear. Fear is operating at a more significant level now and will continue to be a latent or overt factor in consumers and their advisors, in customers and consumers' point of view about long-term care going forward. So even in situations where there have been significant infections, where there's been significant death, where there's been significant negative stories, we need to take charge of those stories and begin to directly address what we can do about fear. And there's very good research about communicating in environments that are fearful and how we can manage the messages to assuage or reduce the levels of fear in the audience. Finally, we need to do a much better job at service error recovery. And so there's a science around service error recovery. And you might say categorically that there has been a service error in long-term care, and it has been our inability to properly manage the COVID-19 outbreak. Many care homes, many nursing centers, many nursing homes, many domiciliary care agencies, many congregate care centers have done a wonderful job, have led the way, and we need to do a better job of understanding and communicating about those situations and learning lessons from those providers. But we also need to adopt a more scientific approach to service error recovery. And here are the keys to service error recovery. First of all, you've got to know when an error occurs. And service errors can occur in a variety of different ways, but you need to be, if you're the manager, owner, operator, leader within your organization, those errors need to find their way to you. And in many cultures, many organizations, frontline workers hide the errors out of fear of retribution or not wanting to look good or afraid of what the outcome will be. Well, that doesn't help anybody. You need to be able to identify the errors. Then we need to apologize. Very large research in the United States has shown that the major reason nursing centers in the United States get sued, legal action taken, is because nobody apologized. And when you ask the nursing center managers why they didn't apologize, it was because they were afraid of getting sued. So this is a very negative cycle that needs to get broken with a simple apology and an offer of a solution. So we need to apologize and offer a solution, then do the solution, do what you say you were going to do, and then later on, remind those involved of what you did and how you addressed the situation. We have terrific resources on our website. We have a presentation called Satisfaction is Cheap, Loyalty is Priceless, that drills down into the science, the behavioral science associated with effective service error recovery. This is very well researched and grounded in business, in the business press, and in academic research. Item number 3 is we need to get serious in the sector about efficiency. Efficiency is a very specific word, and it's not a code name for, efficiency is not a code for eliminating staff, which is very often what efficiency is taken to mean. Oh, in efforts to improve our efficiency, we're laying off staff. No, that has nothing to do with efficiency. That's cutting costs, and that's removing overhead. Efficiency is outputs for inputs, and efficiency is related to productivity, but productivity is not equal to staff reductions. You don't become more productive by reducing your staff. You become more productive by having the right person do the right job at the right time with the right materials and to do the job right. We did a major survey among care workers, frontline care workers, about what the difficulties and challenges they had in providing morning care. You know, personal care attendants go around and do morning care with individuals, the basics of grooming, toileting, cleaning, bathing, that type of thing. And what we found in hundreds of interviews, what we found was that the personal care attendants who had difficulties were, the 80% of the time, it was because they didn't have the washcloths, the basins, the soap. And when we looked further, it was because other more experienced and more cynical care attendants had sequestered that stuff, had staffed that stuff away so that they had a secret pile of this stuff put away. And why did they do that? Because they had had the experience that the staff who reported difficulties had had, and this whole thing was just a mess. And it got fixed. It got fixed by talking to the frontline staff. So efficiency has to do with the right person with the right qualifications, doing the right job at the right time with the right materials, and doing the job right the first time. And efficiency is often talked about in the context of technology and information. Long-term care is the land that technology and information systems left behind, unfortunately. And the technology that's available today on tracking materials, tracking actions and individuals, pathways within a care setting is very good, and it can improve technology, but we mustn't wait for the money or the advancing technology in order to look at efficiency, to talk to the frontline care staff, to talk about how we can improve efficiency and make the outputs more effective for the inputs. The fourth thing that we can do is differentiate. And in the current market, we need to defend, fortify, and emphasize value, the importance of the benefits being derived for the care being provided. We need to protect, defend, and fortify current staff. We need to do better with service error recovery, and these will help innovate for efficiency and to differentiate our service in the local marketplace area vis-a-vis other potential providers as well. So in conclusion, the current situation is that we've got some myths about aging. We're in for another 6 or 7 or 8 years of declining age qualified, the size of the age qualified consumer market. The likely recovery models and scenarios will be challenging. Our best and most effective response to this is to take charge of the messages, take charge of what we can do within our organizations to improve efficiency and effectiveness. And that is the message that I hope to leave with you today. Although, as George Bernard Shaw famously wrote, the single biggest problem with communication is the illusion that communication has taken place. And with that, I would be delighted to see if we can answer questions.
Thank you very much, Irving. So now let's open the Q&A session. And I can see that we've got some here now. So the first one, Irving, is what do you mean by taking charge of the narrative? How can we do that?
So that means you don't wait for the media to show up at your front door to begin to submit stories and invite people from the media, from the community, to talk publicly about what's occurring in your community, the positive stories. In every long-term care setting that I've visited, and I've been in thousands of them, there are serious people, sometimes funny people, but earnest, professional people doing what they believe is the right thing for their charges, for the people for whose care they're responsible. And we need to get those stories out. There have been some extraordinarily clever things done, for example, about keeping residents in touch with and in communication with their physically separated family members. Those stories are wonderful stories. Some of them are exceedingly clever. That's what I mean by taking charge of the narrative. You don't need a public relations firm. You don't need an advertising agency. You need to think about what are some of the extraordinarily clever things or persevering things or heartwarming things, funny things that are occurring here, and how can we turn this into a message that's sent out, presented to our communities in order to show the value of what's occurring through our service. I hope I've answered that question.
Yeah, thank you very much. It's about using the leverage. So how can we, the next question is, how can we improve out PR when I cannot afford a professional agency? How can we improve our PR?
So that's another very good question. Thank you. I believe that the steps that we should be taking now are to create lists of media contacts in the press, both electronic and print, and the local authorities, the media, everyone, our stakeholders. And we should have their email addresses, we should have their preferences, especially for the media, the print media, what their preferences are. And when we create these stories, when these stories come to us about something extraordinarily effective that an employee or staff member has done, or some heartwarming connection that a resident has made, we should be making these stories with people's approval, of course. We should be making these stories and images available to those members of the press, to those digital news outlets, through our newsletters, through our digital channels. We should be making those messages. So we can start now without investing in a PR agency, a professional firm. We can do those things today and we should be doing them.
Thank you. We have a follow-up from that question, which is, what if negative press has already surfaced and people are biased due to the information?
It's another very good question. And the way, so there's two components to that. So there's a negative story about your nursing center that's not, you're not referring to the general cultural negativity, but there's a very specific negative story about your center or about your service. We have a PowerPoint presentation and I think a webinar on crisis communications on our website, and I would refer the person who asked that question to that resource. But the basic principle is, first of all, you get out up in front of that story. You as the leader take charge of that story by being visible and responding to it. Even if you can't say much because of GDPR or because of HIPAA, or because of the sensitive nature of identities of the individuals, you can step out in front and say, this has occurred. We are working with the local authorities. Our commitment remains to the health, well-being, and success of our staff, our residents, our patients, our consumers, and we will do X, Y, and Z. We will be back in touch. We will communicate as we are able, and any questions should be directed to me, to the leader. I'm ready and able to answer because our commitment is to our employees and staff. So you take the negative and you make, I call it a sandwich. You make a positive statement, you describe what occurred to the extent you're able, and then you repeat your commitment to the well-being of those you're caring for. So that's how you get out in front of a negative story. But there's far more to it than that, obviously, and I would refer you to our website where there's the webinar on crisis communications.
Thank you, Irving. So we have a couple more questions, and one of those questions is, in my market, a person can make more money working McDonald's than a nursing home, and they get all the Big Macs they want for free. How do you recommend finding new aids for the nursing facility with such competition?
Okay, this is another great question, and whether it's a McDonald's or a Kroger or a Tesco, long-term care providers are competing for the same frontline workers as are those other service-intensive or service-related sectors. And what the research has shown is that there are specific psychographic profiles of individuals who would prefer to work in a nursing center, who would prefer to work in domiciliary care, who would prefer to work at a care home as opposed to a Tesco or a Kroger's or a McDonald's. So our job is to use the research to find those people. And we find those people by using the trigger words that will attract them preferentially to our recruitment efforts as opposed to McDonald's recruitment efforts. Because what McDonald's and others, what these high volume, high churn employers are doing is they're working on the numbers. We can't work on the numbers because we don't have that big a budget. What we have to work on is we have to work on the psychographics. So we have to carefully segment. And the first step in doing that is to talk to your best employees. You talk to your best employees and you understand why they like it, why they're so loyal, what they liked about it when they first started, why they stayed, and use those words, those keywords in an internet search way of speaking, either in print or online promotions in order to preferentially attract those staff who would prefer to work with you as opposed to a McDonald's. I
Thank
hope
you
that
very
answers the
much.
question.
Yes, thank you. Couple more. Have you got time for these?
Yes.
Great. So one of the questions is, will families recover their trust of care homes after COVID?
What a good question. First of all, there's a baseline of demand in the long-term care markets that's driven by physiology and by clinical conditions. There's a baseline demand that really will not go away. And that is, we all know, neuromuscular disorder, dementias of various types, disabilities of other types. So there's a baseline demand that will endure. Above that baseline demand, there's quite a bit of variation in acceptance and penetration, as I talked about. Families will respond to the question about long-term care based significantly upon what's referred to as personal access. So what stories have families heard through their networks or through the media they consume? What stories have they heard about long-term care? If in your marketplace area, the stories that are running are primarily negative, the messages and predispositions that the families will have will be fundamentally negative. If you can counterbalance those with positive stories, if you can share, as I was attempting to explain earlier, I hope to some degree of success, if you can share positive messages, take charge of the narrative within your marketplace area, then there's a chance that the families will have absorbed some of those messages. But the background of fear can be overcome by reporting very specific information and how you have responded to COVID when the consumer asks you about it. So there's a very specific rigor associated with that. But in general, families will learn to fear less as the news cycle shifts away from the negativity in care homes and shifts toward, frankly, toward other topics. Already, there's signs that consumers are becoming weary of the negativity in messages around care homes, nursing homes, around healthcare hospitals in several marketplace areas. So I believe as the news cycle shifts, the negativity will abate. But we, as taking responsibility for the messages, need to understand it probably won't go away completely for years.
Thank you. And one final question. Most of the so-called service errors are because of staff shortages. How can we recover from these?
Okay, what a great question. So service errors occur in part because somebody doesn't answer a call light, or someone who's taking care of Mrs. Jones gets a call that something is happening with Mrs. Smith that's more urgent and has to leave Mrs. Jones to go attend to Mrs. Smith. And then when the caregiver returns to Mrs. Smith, maybe she was longer than she told, she wants to be an optimist. She said, sorry, dear, I'll be back in 10 minutes. And it's fully 25 or 30 minutes or longer. And when the caregiver comes back, her first instinct is to apologize, which is good. I'm sorry it took me so long. But then she wants to make an excuse. She wants to give a reason why she took so long. The simplest thing to say is we're short-staffed today. And that's an incredibly bad thing to say, even if it's the truth. We must find other things to say So in service error recovery, the first thing to do is to attempt to prevent the error in the first place. And if the error is upset around being short-staffed, where did families or patients hear about being short-staffed? They heard it from the staff. So the first thing to do is to make sure that that does not occur. The second, looking at the steps associated with service error recovery, the first step is to say, I apologize. The second step is to offer some solution. You know, when I leave here, when we're done here getting you dressed, Mrs. Smith, I feel badly that you waited as long as you did. I know you like that ginger tea. I'm going to go get you a nice cup of that ginger tea. And then the caregiver goes and gets the cup of ginger tea, brings it back, and reminds the consumer, here, dear, I really did feel badly that you had to wait so long. Here's that cup of tea that I promised you. So that's how that gets handled. And that's how service error recoveries that are associated with the fact of short staff get addressed.
Excellent. And on that note, I want to thank everyone who attended today's webinar, and thank you, Irving, for presenting today. We hope that you all found it very informative, and please can you take a moment to tell us how we did. You will be asked to fill in a very brief survey at the end of this webinar, and this is the only way we can learn how to improve our presentations. Thank you again, and we look forward to seeing you at a future program. Have a great afternoon, day, morning, wherever everyone is, and stay well. Thank you.